but it's got some obstacles. It's a customized product that has to be developed for an individual patient, and sometimes there's some difficulty in collecting those cells. There's a period of time in time when you collect the cells and you're able to deliver the therapy, and so some patients can progress during that time. So, and then there's all the different constructs that Fred was talking about. So, Krishna, do you think there's is there anything to this? The 4-1BB, the CD28, the retrovirus, the lentivirus, does that make any difference? Do we know that the difference is now?
Yeah, good questions, and I think that this is something that we're all trying to understand. So I think just to go back to that basic biology, we know that signal 1 is delivered through that through the T cell receptor, and we have that CD3 zeta intracellular domain that's common to all of these. But typically there's a second domain that's fused, and the two that are in place in the early generation of trials are CD28, and then a second domain called 4-1BB. So these are both, things that, again, normally would be a receptor on the T cell that would receive a second signal through a unique ligand, but in the context of the CAR, they're basically artificially delivered through the same genetic construct. So, for example, the KITE KTC C19 trial uses a construct that has the CD28 intracellular domain. And that's also true of the Juno JCAR 015 trial, which is being in place for acute lymphoid leukemia. The JCAR 017, which is the second trial in the setting of non-Hodgkin's lymphoma, actually uses the 4-1BB domain, and in the Novartis trial, the first trial, is also using a 4-1BB domain. So theoretically, the kinetics of engagement of the second signal through these receptors can vary, and therefore when you deliver it artificially, the cell can react differently. So there are some data that suggests that perhaps CD28 based secondary signal will give you an earlier expansion, and then the 4-1BB signal may be slightly later and perhaps lead to greater persistence. I think that these are, I would still say, although there's obviously strong basic biology behind these concepts, we now have, rather than trying to say too much about which ones matter, right now we have, almost 200 patients that will be treated in the context of these early stages of clinical trials. I think all of these companies have very smart individuals who are really doing very extensive correlative studies. And those correlative studies include the measurement of CD4 and CD8 cells and B cells and dendritic cells and monocytes, other cells that may affect the expansion. And then secondly, they're looking at a whole range, typically 30 to 40 analytes in the serum to look at serum biomarkers. So I think, while we can speculate, we will soon know which constructs and in the context of which patients and what happens in the cells and the serum will expand. So I think we'll have that data soon.
I think it's important for our audience that maybe we summarize what's happening when we give the CAR T cell beside the production, the biology behind it. That's fascinating, is that we actually inject those cells and they're very well tolerated for the first few days. And a few days later, very often patients develop fevers, chills. That's called a cytokine release syndrome. And that's going to be very impressive. We try to not use steroids because we don't want to impair the expansion of the T cells, which can be very, very impressive and very quick. And then eventually some of these patients can become comatose, have to be intubated, and have seizures and speech cognitive issues and all that. So it's very impressive clinically. So that has to be done in centers that are usually familiar with this approach and context of dose therapy and transplantation. But what is interesting is that we have tocilizumab, an anti-IL-6 receptor that really helps control, and it was sort of serendipity that happened initially at UPenn, and this young girl that was treated and was having very severe toxicity, and we did very well once when ALL was in the ICU, did very well once they gave her tocilizumab, and she's still in remission. So I think this is really important to realize as we're learning. This is very interesting that if you have a patient that has refractory to standard therapies, this is something that definitely we have a center nearby that needs to be looked at for a patient because it gives opportunities. We have, among the first responders, there's some patients where the 3 first refractory follicular lymphoma multi-heavily pretreated have been in remission more than 5 years.
So Fred, getting back to what Andre was talking about a second ago in terms of centers that do this. You've put together a group at Moffitt that just specializes on immunotherapies for a special group of doctors and nurses that take care of these patients. So clearly this isn't something that's been coming to the average community hospital in the near future, but talk to that a little bit.
Yeah, so there's two reasons for that. I think, first of all, these therapies are cell therapies, cellular therapies that require collection of the cells from the patient. It's an autologous cell therapy product. So you need access to pheresis and ability to schedule that. In addition, as Andre mentioned, this can be a very toxic treatment. Cytokine release syndrome is seen with all the different constructs that we've mentioned. The timing of that cytokine release syndrome may be variable depending on the constructs or even the disease or the disease burden. But what we do see is those high fevers, chills, hypotension, hypoxia. And so you need a specialized team that's familiar with those toxicities. And what we did at Moffitt Cancer Center is we got together with the hematologic malignancy physicians and the transplant physicians like myself to really pair up to create a team, as you mentioned, that could focus on these toxicities and the administration of this treatment from the start to the finish, not unlike a hematopoietic stem cell transplant. So as this therapy, anti-CD19 CAR T-cell therapy, becomes more widely available, it's likely that we'll see its use in centers that have familiarity with hematopoietic stem cell transplant. And we've used that same paradigm. We call it the Immune and Cellular Therapy Program, or ICE-T for short, and it's caught on. We actually now have 7 or 8 different clinical trials that we have on that program. We have a specialized clinical service to care for those patients, and it not only includes CAR T-cell therapy, but T-cell receptor therapy, which is slightly different than CAR T-cell therapy, but also on the horizon for solid tumor and hematologic malignancies. And I also want to speak to the other toxicity that Andre mentioned, which is neurologic toxicity. We talked about cytokine release syndrome, but generally a little bit later than the cytokine release syndrome is a neurologic toxicity. The pathophysiology of this remains really undescribed or unfigured out. What's causing it? We do know that the CAR T cells can be found within the central nervous system, within the CSF. Whether what the cause of that is being looked at. But the neurologic toxicity is very unusual. It's most similar to the neurologic toxicity seen with blinatumomab, the BiTE antibody, a CD19 targeted BiTE antibody, where patients can get kind of a locked-in syndrome where they're awake, they appear alert, but they can't answer questions. And so, again, you need a specialized center that becomes familiar with these treatments and is able to manage them, because these toxicities are generally completely reversible.